Welcome to our second lecture of our HIV Bootcamp series. Today I will be talking to you about HIV test and treat, initiating antiretroviral therapy, okay? This logo at the top is just a reminder of a few weeks ago was National HIV Testing Day. You can test for HIV any day you please, right? However, it's just to emphasize the importance of actually getting that screening done. So without further ado, let's dive into a little bit about the background relating to this. So in 2020, there was an initiative set forward called Ending the HIV Epidemic. Basically, they identified what we call some priority 1 jurisdictions, hotspots, where HIV was most prevalent and also where the incidence was high. And the plan for the initiative was to focus your HIV resources, testing, treatment in those hotspots in order to end the HIV epidemic. But we know that by a certain, like 2025, but we know that we're not really gonna reach that goal, but we can try. Even though in this map, they identified priority states in light blue and Florida is not necessarily entirely shaded, there are priority counties in dark blue. Does anybody want to take a stab at what these counties are? Hillsboro's right there. Which other?
Miami-Dade.
Miami-Dade.
Too.
Pinellas, correct. Which other?
Duval.
Duval. I'm impressed with whoever knew Duval.
Is that San Juan? No, that's
San Juan. Where?
San Juan.
Okay, people, this is important.
Yeah, you're right.
Puerto Rico is, San Juan, Puerto Rico is a hotspot. Please note that Puerto Rico is not here in relation to Florida. This is just for it to fit in the map. Okay. So good guesses, everyone. Duval. I was like, well, that must be Duval because by exclusion. But it is, so what I want to show you with this is that it is important for us to know how to diagnose HIV and treat it because of where we work at, right? So most of the content from this lecture is from your it's National HIV Curriculum. This is a free online resource. You can make an account. You can go through the question bank. It's very good material. And these are the modules that I will be covering today, mainly focusing on HIV diagnostics, how to interpret them, how to know when you have an acute and HIV infection, and then what to do after that. Link to care and also initiate ART. So first, I brought 4 clinical case scenarios of real patients that I've seen here and with different diagnostics, and I'm hoping that you'll be able to help me interpret this. So it all starts with an ID consult. So this patient was referred to us maybe a year and a half ago and for a new HIV diagnosis. He went to the ER tested him and got back a positive result, and then they're asking us to evaluate him ASAP. So my scheduler, Carla at the time, still with us, but not in that scheduling modality, called him to set up an initial visit. He said, yeah, sure, I'll come into clinic, I'll get the labs done, but tell the doctor that I want her to repeat my HIV test because I think it's a false positive. So these were his initial tests. So the next question is this HIV test result true positive or a false positive? Because maybe the patient is onto something. We do see false positives. So anything you can tell me from those labs?
What's the second?
Yeah. Confirmation, correct.
So that's the right name.
So good observation, but let's talk about that a little bit more. This is your fourth generation screening test antigen antibody. Basically looks for the P24 antigen, which is a viral protein in the HIV capsule. The antibody it's looking for our immune response to that HIV viral protein or epitope, okay? It looks for both, but it marks positive when it encounters one of them, either the P24 antigen or the antibody. It doesn't tell me which one. Then you have the supplemental test, which is the confirmatory test, and it looks for antibodies against HIV-1 and antibodies against HIV-2. It's not the viral that we're seeing here. So he was previously tested in 2020, 3 years prior, had a reactive screening test, and then a positive confirmation for HIV-1. And then of note, been tested for STIs a couple times and was positive in January. So what are you guys thinking? Is this true or false? No wrong answers. Looks true, right? Just by looking at it, looks true. So the next thing I want to know is, why was he screened for HIV to begin with? And is it routine testing, right? Because we do know that all individuals between the ages of 13 and 64 per the USPTF should get screened for HIV at least once. Even outside those age limits, if there is high clinical suspicion or some risk factor, you can test. Or was he having some type of symptoms, or did he have an exposure? So I went into the ER's note, provider's note, and this is a 46-year-old cisgender male who went to the ED requesting to be checked for STIs. Apparently his girlfriend went to her OB-GYN, tested positive for chlamydia, and obviously she was told, you have to tell your partner to get tested and treated. So this is a board question. Whenever you are looking for a specific STI, don't just test for that STI. You have to test for gonorrhea, syphilis, and HIV, plus minus hepatitis B and C. Okay, this is going to come in your IM boards probably. It'll probably come up in your ID boards as well. So whenever in doubt, I turn to this algorithm, which I really like, from the CDC and the APHL, which is the Association of Public Health Laboratories. And let's go through it. So we saw that the antigen antibody was positive, and then the complementary was positive for HIV-1. So this is likely a true positive, like you guys said. And this is consistent with a new HIV diagnosis. So the 4th generation test, is a screening test, is pretty good. It's 98% sensitive and 98% specific. It means that it will correctly identify an HIV infected person. And if that person has chronic HIV infection, note, not acute, that initial antibody test should be positive as well, but then that specificity is increased when we combine it with the supplemental or the confirmation test. And then the predictive value of the test, it depends on 2 things: individual patient risk factors and the prevalence of HIV in the community, which we see is high here. So it is not 100% specific or sensitive. Does anybody know why? Correct. You can get false positives. And we'll talk about that in a few. Mind you, we're only going to focus on HIV-1 because it's what we mainly see in this side of the world. HIV-2 is rare. We mainly see it in Africa, and it's a whole topic in itself. So we're not really going to explore these 2 options. We're more going to go through these sides of the algorithm. Okay. So part of the caveats or the limitations of this test is that there's a seroconversion window, okay? Basically, the amount of time it takes our body to develop an antibody titer days following HIV acquisition. So on average, it takes us about 3 weeks, 3 to 4 weeks to get an antibody response. So if it's too early and you don't have an antibody response, that's a possible negative. That's false. And then there's this thing called an eclipse phase. Basically, that first 10 days after day 0 following HIV exposure, it is possible that no diagnostic test is able to pick it up, right? And it basically relates to the viral load. It's the first thing that comes back positive, and it can be detected in the blood as early as 4 days following HIV exposure, but it can lag to 10 to 11 days. And the P24 antigen doesn't show up until day 10. So that's that 10-day, and obviously the antibody takes longer. So that's what we call the eclipse phase. So this is another patient that I saw, and then basically you can see here that they were tested in April 2021, came back negative. Not sure why they were tested here. And then in September came back reactive, but had a confirmation that was negative. So what are you guys thinking now? Is this a true positive? You need more information? Or is it a false positive?
PCR.
We need more information, right? It could be a false positive, but we do need more information. So what do you do next? So back to that algorithm. So we had a positive antigen antibody and then a negative confirmation. And this is what we call an indeterminate result, discordant results. So the tiebreaker is the PCR or the NAT, which is the nucleic acid amplification test, or the viral load, RNA viral load. There's many names for the same thing. So while you await the viral load, is there anything else you would like to know about this patient? Yeah, exactly. Exactly. The pretest probability when interpreting this is helpful. So this patient was referred to me when I was in primary care and did some HIV back then. And it was a man who had sex with men, had presented to the ED with a urethritis-like picture, dysuria and discharge. Had said he had a high-risk exposure to somebody he thought had syphilis, and also was IVDU. Meth was his drug of choice, and also had comorbid mental health illness, which was bipolar. So based on this, you guys, what are you guys thinking? True positive, false positive? So the viral load came back and it was 2 million, over 2 million copies. So this is a true positive, but this is what you would call an acute HIV infection, or early, because it didn't have enough time to develop that antibody. So that, if you guys can tell, those viral loads, there's one from September 20 and one from September 27, that a week apart, and there's a marked decrease from 2 million to 74,000. Do you anything to explain this? What do you think happened there? A little bit of both. So the virus, right? Initially it peaks and then it plateaus and it reaches like a set point. But here there was some treatment, and more than treatment, this patient received NPEP, non-occupational post-exposure prophylaxis. Because of the nature of his high-risk exposure and all of these risk factors, the ED actually did give 28-day supply of Truvada plus Raltegravir, which explains why it went down so fast, so quickly, which was even better because then we just had to transition from NPEP to just treatment. Maybe just simplify it to a Biktarvy or something like that. Okay, great. So that was an acute HIV. In this phase, you can get acute retroviral syndrome, which is symptomatic illness, but very nonspecific: fever, chills, night sweats, a rash, dysuria. You might get a question on this on the boards, on the IM boards, actually. So it's important not to miss this. And then early HIV infection is that 6-month period following HIV acquisition. So he was previously negative in April, and it only had been maybe 4 or 5 months. So this was definitely an acute. So I like this chart because it shows the different markers and how they peak and plateau, and then what the timing is after HIV acquisition. So case scenario number 3. We have here positive. So this patient was tested in March. We have a positive in March, again positive in April, antigen antibody screening test, but the confirmation was negative twice, and he was negative for other STIs. So what are you guys thinking then?
What the confirmation is?
An antibody. The antibody. So that's why in the prior it was an acute HIV infection, because it picked up the 24 antigen, but it didn't. It was so early on after exposure that the patient hadn't developed antibodies yet. So I'm thinking that prior patient, we probably caught it maybe within 2 weeks, 3. So you probably need a little bit more information right here. So again, the algorithm, we have another discordant result here, indeterminate. So the viral load is your tiebreaker in these cases. So while we await, let's take a look at that pretest probability. So this was a young 30-something-year-old Hispanic patient. He was tested as routine screening because he established care with his primary care. He was a man who had sex with women. He didn't have any symptoms. He was monogamous with only one consistent female partner whom he started engaging with 6 months prior. So he came to me maybe March, April. They started in September. He had gotten tested outside the VA for HIV prior to September, and it was negative. And then he had only been engaging with her in unprotected condomless sex for the past 3 months. But apparently she was HIV negative as well, tested outside the VA. No IVDU, no occupational exposure, nothing, no travels, nothing like that. Okay. So what are you guys thinking? Low pretest probability. So this could be a false positive. So here we go. Viral load was undetectable twice. And his CD4 count was well above 1,000, the 44%. So this, I called it as a false positive. Okay. Which is very stressful for patients and providers because, how do you give this reassurance? I saw this patient with Jesus, and Jesus was almost going to give him some Biktarvy. I'm like, no, not yet. So false positive HIV test is defined as a positive HIV test result in a person who does not have HIV. And this occurs mainly due to cross-reactivity. Either something is cross-reacting with the test, right? It could be the antigen component or the actual an antibody your body developed, a polyclonal antibody, that is making this test light up when it really is an HIV, okay? So scenarios where this can happen is pregnancy, vaccines, either recent inoculation of a flu vaccine or other vaccines, or the patient participated and received an investigational HIV-1 vaccine. You can see that then. Autoimmune disorders like lupus, collagen vascular disease, misconnected tissue disease, RA, having received gamma globulin, prior blood transfusion, even recent viral infection. In this case, for example, in 2020, they saw during the COVID pandemic, 2019, 2020, an uptrending in HIV positive, false HIV positives. And there was a study, it was published in a CID, and the conclusion was that it was possible that there was a viral protein in the COVID that was similar to a viral protein in the HIV, and that's why it was causing this test to become falsely positive. As opposed to, right, other conditions, you may have an antibody that especially the polyclonal ones that recognize different epitopes and different antigens, and that can cross-react and look like an antibody towards HIV, but it's actually about something else. So also, there was another article on chemotherapy. Patients, they studied this in cancer patients and chemotherapy and saw that there was a higher incidence in plant alkaline chemotherapies. And then in the CAR T, right, you might have seen this already in Moffitt. So CAR T means chimeric antigen receptor T cell chemotherapy. So this is the vector that they use in the development of this therapy is a lentivirus. And we learned last week in Dr. Ronald's lecture that HIV is in the lentivirus family. So this is how it interacts and cross-reacts with the test. And then plain old lab error. So this is well described in the literature as a few months ago in 2024, this one came out in the CID, the top left one, and they studied it in cancer patients. This is the article I was talking about, that they saw an uptrend during the pandemic. And then, but as you can see here, it's been described in the literature since the 80s, since the 90s, when the HIV epidemic started, and they started developing this test. And we've come a long way in making these tests a lot better, but it still has its limitations. So here, we see a case report described in a patient with lupus. This happens a lot, actually, in the blood donation screening. I had a nurse friend who had received, her son donated blood and received a false positive HIV letter in the mail. So imagine how scary that is for people. She told me about it. I was like, what? And then they got to repeat it, and it was all good. But it's scary. So this was New England Journal of Medicine article in 1988, right? In the peak of the, when everything started. And I like to put the quote here: the potential consequences of incorrectly informing a person that he or she is infected with HIV is severe, right? They can have anguish, fear, depression, lose jobs, have health insurance denied, aborted pregnancies, and even possibly suicide. And then I really like this one here, is that it does cause significant mental distress for the individuals, right, while they're awaiting confirmation. And it does lead to unnecessary workup, unnecessary initiation of antiretroviral. And that's why ID, right, experts in the field are needed to provide this reassurance, not only to the patient, to the patient's partners, as well as their primary cares, and even to ourselves, right? As you can see, we already talked about pregnancy and autoimmune disorders, but it can also be seen in other infections, not just COVID, but TB, toxo, schisto, and rickettsiosis. Celia, do you have a question?
Yeah, I don't know if this is like a
Let me see
thing
if I
or
can hear you.
not. Oh, can you hear me? If not, I can type it. Can you hear
You're
me?
unmuted, but I can't hear you. Let me see if maybe I have my my speaker muted. Okay. No, let me see. Do you want to type it in the chat? Not sure why I'm not able to hear you. Unless I take this off.
You said in patients who are elite control, is it possible to have negative antibody?
That's a good question, Celia. We're gonna show you a clinical case scenario about that right now, actually. She's like reading my thoughts. Okay. So to answer Celia's question, we'll finish up this clinical case scenario, and we'll go to the elite controls next. But this patient, I actually did quite a workup on him. Chlamydia, I tested him for other STIs, tested him for tuberculosis. My toxo got canceled by my pathologist because let's edit that part out. And then I checked to see if he had any hepatitis co-infections, who is immune to Hep A and B, likely due to vaccination, never exposed to Hep B or C. I did a gamma globulin panel to see if, because we have to look for other immunodeficiencies. There's been reports of false positive HIV in CVID, and that was normal. And I did a kind of a room panel, and his rheumatoid factor was negative, but his ANA and his RMP was positive. What does that mean? I don't know, right? Because it's not just positive markers. Maybe that's cross-reacting too. Maybe that's false positive too. Who knows? He didn't have any symptoms. He doesn't necessarily meet the diagnostics for him. You would see that pattern in a mixed connective tissue disease. So I talked to his primary care about this because she called me and she's like, so this is a false positive. Are you sure? I'm like, yeah, I'm sure. And I've talked to the patient. I saw the patient twice in clinic. The second time he brought his partner so that I would tell her, like, imagine your partner going to the doctor, coming home and saying, no worries, my doctor said I really don't have HIV. It's false positive. So she came and I told, but it's interesting because she's like, is this patient supposed to seroconvert back to negative at some point? How often do I check it? And there's no guidelines to how often you check them. It's individual case basis, right? You check it if they are having a high risk exposure, but I cannot guarantee that they're going to seroconvert back to negative. They might actually seroconvert to positive if they have a high risk exposure. But interesting, we did have another false positive case. This one's being followed by Dr. Morano Perry. And this patient did have high risk exposures. He was MSM, bipolar, was on PrEP, and then had this false positive, and then he kept getting checked for HIV every 3 months because he was on PrEP, and then all of a sudden, a few months later, went back to negative. We don't know if he was maybe transiently exposed and cleared because of the PrEP, but stuff like that happens. So the next case, this is a patient that is a veteran, but not very known to ID clinic because he's mainly followed with a private ID physician. So there's limited history, but apparently he first tested positive for HIV back in 2003. Imagine 20 years ago. And apparently he was previously on some type of ART, a DEPC. But then as of late, like in 2022, ID got consulted because the patient told his primary care, no, I don't have HIV. I'm not on ART. So I don't know why you guys keep calling me to give me an appointment with ID. So this is maybe Celia's question. This is how his labs look. So we have an antigen antibody dating back to 2015, but we know he was tested positive outside of the VA dating back to 2003. And then his antigen antibody is reactive, but the confirmation was always positive. Here it was canceled by microbiologist because they said he was already previously tested. Why test again? The answer is there. So in the elite controllers or long-term progressors, the difference between this population and the false positive or the acute early is that you will have a positive confirmation test. Okay. So I hope that answers your question, Celia. Their confirmation and supplemental antibody will stay positive. The real definition lies in what they're doing with their viral load and their CD4 count, which is in this patient, obviously he was on and off at the VA, but so we really can't trend this CD4 count, but had a 20.4 and an undetectable in these two scenarios, and apparently had told their PCP that he was off ART. So in this algorithm, it is a true positive. So he does have HIV. He's just in this category, this subset of patients. So in terms of controllers, we have elite controllers and virus controllers. And these are basically people that are individuals who naturally control HIV without taking antiretroviral therapy. So the elite means that they are able to maintain undetectable off ART versus virus controllers is that they maintain a low level viremia. That's the difference, okay? And then long-term progressors is that their CD4 count is above, 500, even 1,000 off ART, and they're able to maintain it that way over a 10-year period. So those are the definitions per the National HIV Curriculum. So this generates a lot of controversy, a lot of confusion for the patient, for the primary care, for the ID doctors as well, that, especially if they're not necessarily following up because they don't feel like they have to. So when is ART recommended? It is clearly recommended if there is evidence of HIV disease progression. If there is evidence that that individual lost their ability to naturally control HIV. So if you see a CD4 count dropping, particularly, that trend and below 500, you could make a case that this patient may benefit from antiretroviral therapy. Go ahead.
We're talking about for the elite controllers.
Mm-hmm.
But
and the long-term progressors.
But if they start to show what you're describing, they're no longer
exactly
no longer fit that.
Exactly. So that's when you would make the decision to start ART, because if they're controlling their virus, right, technically they're at low risk of transmitting to somebody else. But then if their C4 count starts to drop, exactly, they're losing that control. So it's clearly recommended to start ART. The clinical benefit, right, of those that haven't progressed is unclear, but there is a theoretical benefit to it, right? Because HIV is an immune dysregulation disorder. So we do know that there is increased immune activation, increased markers for atherosclerotic risk, right? This is the whole basis, the REPRIEVE trial, that they benefit from the statin because at baseline, they are at increased risk for adverse cardiac outcomes. So this is the other side of the debate, is maybe they might benefit from ART just to control the immune dysregulation portion and prevent that potential comorbidity. But regardless of if they're on ART or off, close follow-up is recommended, because how are you going to know when they lost their control over HIV. So we tried to get this patient back into clinic with us to recheck CD4 count and viral load, but the patient wasn't interested. He wanted to stay with his private ID, and I think he's back on ART. So from what I heard. Okay, any questions with diagnostics for now? Okay, so I think it's very important for us to know those 4 clinical scenarios.
If you have somebody that's like dysregulation, you expect like the antibodies confirmatory tests to be messed up.
Well, there is this thing that sometimes you can see energy or a diminished immune response, but the viral load doesn't lie. So that's why it's a tiebreaker. Now going back to that first patient, the ones that do have HIV, right? What is it that you should order in that initial visit? And you guys, I'm sure you guys already know a lot of this, but at baseline, it's important to get these tests, right? You don't order these tests in the false positive ones, okay? You order them only in the ones that have HIV. So markers of their HIV status is a subset lymphocyte, which here at the VA, it's the CBC is built into that, but at the health department, it's 2 different orders. You want to see their CD4 count and their percent. Their viral load. It is important to get a genotype at baseline. And here at the VA, you have to order 2. One is the integrase genotype, which just tells you the integrase, and the other one tells you the possible mutations to the NRTIs and NRTIs and the PIs. Okay, so it's important, and it won't reflex. So if you have a viral load, the lab doesn't automatically know, oh, let's get a genotype. You have to order it. So it's a high level of suspicion and anticipation. Viral load cutoff, so less than 1,000. It's not gonna, your genotype is not gonna be run. But if it's more than 1,000, it can be run as long as you've ordered it. So please keep that in mind. Hepatitis, it's important to know their A, B, C status, right? Particularly of interest is the B, because we need to know if in our antiretroviral therapy, we need to cover with something that has hepatitis B activity. So hepatitis, the hierarchy is tenofovir is the first line. Lamivudine is second, but it's not as recommended anymore because of high rates of viral resistance. Back in the 80s, 90s, it was first line, but it was used so much that it's not ideal. The first line is tenofovir, but it still retains some activity, but it's not recommended to use. B. And then third agent that treats hepatitis B is entecavir, but this is usually for mono therapy for hepatitis B infection. It has no HIV activity. And you will see your subset of patients that are on a tenofovir-based regimen and cannot suppress their hepatitis B. I have a patient like this, and you have to add the entecavir to their antiretroviral therapy in order to get them suppressed. Okay, so that tenofovir resistance can happen. It's rare, but it can happen. And the viral load will let you know, the surface antigen and the viral load will help you determine that. And then all other labs that we get at baseline is a CMP urinalysis. You want to know what their kidney function is at baseline and during treatment, because a lot of these agents are nephrotoxic, particularly the tenofovir. And then I like to know if they've been exposed to toxoplasma again in the past, because if their CD4 count is less than 200, they can reactivate it. And I have to give them Profi that covers that, as well as G6PD level is important to know, because a lot of these prophylaxis, you can have issues if you're G6PD deficient. And then HLA, it's a genetic test. You need to consent the patient for it, okay? Dr. Vega and I, we joke that if you don't consent a patient for a verbal consent for a genetic test and you order it and it gets done, that's a felony. So imagine going to jail for something like that. It's not a joke, but Dr. Vega and I, we joke about it. Anyways, and then the annual screens is tuberculosis, right? Quantiferon. And the reason being is because patients with HIV are at increased risk from going from latent to active, progressing. And then STI, syphilis, chlamydia, gonorrhea, triple site testing, and then vitamin D, because I need to know how good their bones are, plus a DEXA if they're above 50, especially if they're on a tenofovir regimen. And then other screens are the anal paps. That here we do it only in our male population. Anal paps can be done in women, particularly if they participate in anal receptive intercourse. But here at the VA, we actually can refer them to their women's health provider. They're not like very happy to do it because it's not something that comes up a lot. But if it had to be done, I've worked with them and they'll happily do it. They've done it in their residency, you know. And then lipids, this is managed by the primary care here, but at the health department, you guys manage the lipids. Colonoscopy, same, if they can afford it or if they have insurance. And then cervical pap, the woman's health provider does it here, but I think at the health department, it's the APPs, is it? Yeah, perfect. So this the first patient we talked about, when I brought him for his initial visit, this was his CD4 count. So yeah, it was a true positive, right? And then he wasn't exposed to hepatitis B or C, not immune to hepatitis B. I don't have any info on hepatitis A, never exposed to toxo, was G6PD deficient, and then had a positive chlamydia. So he was treated for that chlamydia when he went to the ED initially. So, and then a couple of days later, let's say maybe 10 days later, he tested positive again for chlamydia. Do you guys know how to interpret that?
Not supposed to retest within, like, I don't know, 6 weeks.
So, good, exactly. Two dead viable organisms can be shed 2 to 3 weeks, even after treatment. So ideally, that's too soon for test of cure. Even a month is too soon. So ideally, we keep it, we do it at least at 2 months, 2 to 3 months, okay? And vitamin D was a little borderline low, and the tuberculosis was a negative screen. So whenever you bring a patient to your clinic, just remember the 5 Ps of the CDC for your sexual history: partners, practices, protection, past STIs, and prevention. And you'll get all the information you need. Try not to be judgmental. Don't say you're monogamous, right? No, a lot of our patients aren't. They have multiple partners. They engage with non-binary, transgender. So try to keep an open mind and really get in there into their practices, because that's what's going to determine how you're going to screen them, as well as condom use. So basically, this patient had a pill aversion, so he asked me about Cabenuva right off the bat. He had some chills and sweats, but nothing else. And then when I came to see me, he had the viral load was pending and the genotype was pending. I only had the positive test and the CD4 count. And then, so yes, this was a new HIV infection. And then questions for you guys. So at that initial visit, my viral load and my genotype was pending. Should I initiate ART? Yes or no? Yes. So that's what test and treat means, right? You get them started on treatment as early as possible, even if there's information pending or missing. Is he a candidate for Cabenuva? Yes or no? That's a great question. This wasn't on prep before. No. So not right now, right? Exactly. I need a viral load. Per the criteria here, they need to be suppressed for a 6-month period. I need a genotype. I need to know if there's any cabotegravir or rilpivirine resistance. And I need to know, that before I can, and at least he's Hep B core negative. So it's not a no, but maybe later. Turns out this patient also had a needle phobia. So when I brought up the conversation, I'm like, you have a pill aversion, you have a needle phobia, like, what are you doing to me here? So I brought it up when he finally got suppressed. I said, hey, you want to do the Cabenuva? You're a candidate. And he's like, no, I'm good. I'm like, okay. So at that time, I did start him on some OI prophylaxis. So yes or no? Yes, right? OI prophylaxis, less than 200. Out of those 3, Bactrim, Dapsone, or Atovaquone, keep in mind he's G6PD deficient and has a pill aversion and a needle phobia. So any of those that you would gravitate to. So those are good questions. Those are all the good answers except the dapsone, right? The dapsone with the G6PD deficiency is a no-no, right? Bactrim you can use as a caution, but I am board worthy. You can get hemolytic anemia, right? Some patients, that's actually a board question. Atovaquone has no issue with the G6PD deficiency. Cover, is good coverage, and it's a suspension, which is chalky, and not a lot of people love it. But somebody with a pill aversion might enjoy it. Not enjoy it, but might prefer it. So I did atovaquone for him, and then he was already treated for chlamydia. I checked his hepatitis A because he was non-immune to hepatitis B. So I wanted to know if I needed to do a combination vaccine versus a regular Hep B vaccine. And then these were his immunizations on that first visit. So do you vaccinate or not vaccinate in that first visit? Depends. Yeah. So CD4, ideally CD4 count above 200, right? Ensures better responses to vaccines and immunogenicity. Some people say you're going to start them on antiretroviral therapy. So there is a concern for iris, right? Inflammatory risk, just by starting ART. And that can happen as well with vaccines. Some people just maybe defer it to the next visit, but there's exceptions, right? If there is a high community prevalence of something like in the peak of the COVID pandemic or the flu or the Mpox, then you could make a case of vaccinating that first because risk versus benefits, right? So these are just the life cycle and the drug classes. Please read this and learn this. But the basis here is that these changed in 2022 with the advent of injectable PrEP. So that's a good point that you mentioned. So now when you're going to initiate therapy, you have to think in your mind, has this patient been on PrEP on long-acting injectable cabotegravir? So if they don't have a history of that, then you can go ahead and start your integrase inhibitor, your INSTI, with a 2-NRTI backbone. So Biktarvy, right, which is bictegravir with a TAF and tricytidine. It's a single pill regimen, better chance for compliance. That's why we potent. It's very potent, very well tolerated, high barrier to resistance. And then you can also consider doing dolutegravir, abacavir, or lamivudine, which is Triumeq. However, you have to make sure that HLA is negative, right? Because you can get a hypersensitivity reaction. And no Hep B, because we just said lamivudine is inferior to tenofovir. And then you can either do dolutegravir, which is Tivicay, with a Truvada or a Descovy, right? Which is TDF emtricitabine or TAF emtricitabine. This is new for me, but this is gutsy. You can even do a 2-drug regimen per these guidelines, which is this is Duvada, dolutegravir, or lamivudine. But if their viral load is except if their viral load is above 500,000, so 2 million copies. No. And then you have, if there's no hepatitis B co-infection, and most people wouldn't start anybody on a 2-drug regimen. Most people would do a 2-drug regimen. And then once they're suppressed, and if there's an indication for it, like chronic kidney disease or something like that, or intolerances, then you can transition. And then for those who have used the cabotegravir as HIV PrEP, you are concerned for that integrase pressure. So you would ideally wait for a genotype and probably start them on a PI-based regimen. So you can do, for example, boosted darunavir, which when it's boosted with a COBI, it's Prescovix, or boosted with ritonavir separate, with a TAF, TDF, emtricitabine. There is a pill that combines all of this, which is Syntuza, which is a single pill regimen, which is an option too. So at the Syntuza is darunavir, COBI, TAF, and emtricitabine. Yeah. Yeah. I don't think there is a single pill with a boosted ritonavir. And then you have your Genvoya that is boosted as well, but it has an integrase. Or you can do just Prescovix with a Descovy or a Truvada. Yeah.
Case where you got Biktarvy up the bed, like basically.
So the only part that I would say is maybe women of childbearing potential, right? And the reason being is because it's not as studied, the Biktarvy. So if you're initiating in somebody of childbearing potential or that is pregnant, it's safe to use, but there's not as much data. So like, let's say you have a woman on Biktarvy already, they get pregnant, the perinatal guidelines say you can continue on them. You don't necessarily have to switch if they're well controlled, but off the bat initiating, you can consider doing something else. For example, I had a couple married couple, and female, male, and she told me that she wanted to have another kid or another child. So I started her on raltegravir and Truvada, because TDF is more studied than TAF, and the raltegravir is of the insties is the more studied in pregnancy. But the partner got Biktarvy, so they were wondering, why did she get something different than I? And it basically comes down to childbearing potential. Okay, and then at follow-up, you would like to repeat the basic 4, which is CBC, CMP, viral load, and CD4 count within 2 to 8 weeks of starting ART. A good happy medium is 4 to 5, 4 to 6 weeks. And then you bring them back to make sure that they're taking it, that they're responding, that they are tolerating it, and to follow up the genotype results. And then also it's important to determine how long you're going to keep them on OI prophylaxis, because once they reach above 200 or above 14 over a 6-month period, then you can safely discontinue OI prophylaxis. So, and I started that patient on D3 supplement. Actually, he didn't want me to order it. He wanted to get it in gummy format because of the pill version, but he took it. It came up. And then this is how he did in the follow-up visit. So his CD4 count went above 200, and the viral load was almost near undetectable, and his genotype didn't show any major crazy issues. So I kept him on Biktarvy. His kidney's doing well, and he's immune to Hep A, and his B5701 was negative. So I can do an abacavir-based regimen if I needed to in the future. So basically, that's it. That's how you do an HIV test and treat an HIV linkage to care successfully. And this patient's already virologically, he's been in my care for a year and a half, already virologically suppressed. Initially, you can see them every 3 to 4 months until they get more stable. He's already in the 6-month. He only wants to be seen by me because, right, I was the first person who told him that he had HIV and helped him cope and get over that stigma and the miseducation and the misinformation. And he's retaining care. So this is what we do with HIV screening. We diagnose HIV, we link patients to care so that we can improve their survival, quality of life, and also prevent transmission to other people. So thank you guys for your attention. 5 minutes left. So these are just pictures from our recent graduation. Very exciting time. Do you have any questions or comments before I let you guys leave?